So as far the drugs are concerned, we had discussed about how metformin influences, what is its association with the lactate production, why the metformin is associated with the lactic acidosis, and all these things in the session on metformin. Two drugs which are important are the first line therapy is, one is SGLT2 inhibitors, which we had already discussed. Robust data have come with respect to SGLT2 inhibitors. As far the metformin is concerned, we have discussed earlier, if the EGFR is less than 30, discontinue metformin. If the EGFR is less than 45, always reduce the dose of metformin. Reduce the metformin dose to off. So whatever you are giving. So when the progression is happening, always when the EGFR is less than 30, discontinue metformin. So this is the current recommendation. And after this, we can look into all the available drugs. So the initial two drugs which we can treat safely in our diabetic patient is SGLT2 inhibitors and metformin. Even SGLT2 inhibitors, whenever there is an EGFR less than 30, because this part has not been studied well, whenever there is an EGFR of less than 30, don't initiate SGLT2 inhibitors. So the message is very clear. So as far the metformin is concerned, if it is less than 30, discontinue. If it is less than 45, you can reduce the dose. So two important drugs, metformin and SGLT2 inhibitors, has to be the first and second drugs in most of our diabetic kidney disease patients are concerned. So the next thing that we need to know about is all about sulfonylurea. So sulfonylurea, the typical sulfonylureas that we use nowadays in practice, we use glimepiride, we use gliclazide, we use glipizide. We use glibenclamide also, but glibenclamide is not much used nowadays for various reasons. So the typical three sulfonylureas are used are gliclazide, glimepiride, glipizide. So all these sulfonylureas can get accumulated in chronic kidney disease. Is there any favoritism, or is there any drug which favors or again or should not be used in chronic kidney disease? There is nothing like that. So gliclazide, as far as concerned, it doesn't produce an active metabolite. That is the advantage of gliclazide. It doesn't give an active metabolite. But the plasma half-life of gliclazide is very higher. So if the patient is more prone for hypoglycemia and all, so gliclazide is not a preferred drug. Rather, glipizide, which has got a very short half-life, can be used. But the problem with the glipizide is it has got an active metabolite. So we can choose between these two drugs. So gliclazide is something like a long-acting insulin, which doesn't have an active metabolite, but it has got a very long T-off. So if we want to use it for a prolonged period, we can use gliclazide, which has got a least effective among all these drugs, at the same time most safe. So gliclazide will be effective as something like a long-acting insulin, whereas like glipizide, as far as concerned, it has got a T-off of 2 to 4 hours, but it leaves an active metabolite. So if you want to use something like a short-acting drug, glipizide will be, or if there is a postprandial sugar alone is typically increased, we can use glipizide. Glimepiride stands in between these two drugs, and even if this glimepiride is studied in patients who are on dialysis also. So glimepiride is also extremely safe. So we can choose between these three drugs. As for the where our patient, there is no big advantage of one over the other. It is the intricate things that matters which sulfonylurea our patient needs. So most of these drugs are very safe.